So welcome everyone to Grand Rounds today. Today we have the Hadar Grand Rounds series, which is sponsored by the Substance Abuse Division. So I will, shortly I'll turn it over to Dr. Frances Levin, who will talk about the Hadar series and introduce our speaker. But first, just a couple quick updates. First is next week we will not have Grand Rounds. We'll take the week off for Thanksgiving. And then the week after that, our speaker will be Susanna Cahalan, who is an author who's written about mental illness, her own as well as other novels, including The Great Pretender. Other nonfiction works. As usual, if people have questions, please feel free to type them into the chat function, and I will navigate that at the end of the lecture. So with that, I will turn it over to Dr. Levin.
Okay. Hi, everybody. This year's Eric D. Hadar Distinguished Lecture will be delivered, as you know, by Dr. Dorothy Hatsukami. This event is part of the annual lecture series on substance use disorders established in 2015 by the Eric D. Hadar Family Foundation. In addition to the endowed fund for the annual Hadar Distinguished Lecture, the Eric D. Hadar Research Fund provides support for fellows and faculty, pilot projects, and laboratory infrastructure. Since 2016, the Eric D. Hadar Distinguished Lecture Series has expanded our knowledge and understanding of both substance use disorders and the treatments available to those dealing with these disorders. Today, we are deeply honored to have Dr. Dorothy Hatsukami be our 5th annual speaker. She is the Professor of Psychiatry and Behavioral Sciences, Forster Family Chair in Cancer Prevention, and Associate Director of Cancer Prevention and Control of the Masonic Cancer Center at the University of Minnesota. Her areas of expertise include nicotine addiction and its treatments, and tobacco regulatory science assessing the toxicity, appeal, and addictiveness of various tobacco products. She has over 450 peer-reviewed publications and received a number of awards for her work. She has served on numerous scientific advisory boards or councils for the US government, including NIDA, SAMHSA, ONDCP, Interagency Committee on Smoking and Health, and the FDA Tobacco Product Scientific Advisory Committee. She is currently a member of the World Health Organization Study Group on Tobacco Product Regulation. She has served as president of 2 scientific organizations, the College of Problems of Drug Dependence and the Society for Research on Nicotine and Tobacco. She really is a giant in the field, and I am so delighted that she agreed to be here today to talk to us. And it's my pleasure to now welcome her, and she'll be talking on tobacco harm reduction, controversies, and a path forward.
Thank you, Frances, for the I'm thinking you can, hopefully. Thank you so much for inviting me to give this presentation. And I feel really quite honored to be selected as the Hadar lecturer. So thank you. And these are my disclosures. I do get funding from NIH as well as the FDA, and none of my comments reflect the opinions of any of these agencies. I want to say that it's really meaningful for me to actually come and lecture at Columbia University because it was the home of one of my, a couple of my favorite colleagues, the late Marion Fishman and Herb Cleaver. And I actually had the privilege of writing an article with Marion that was entitled Crack Cocaine and Cocaine Hydrochloride, Are the Differences Myth or Reality? And what we concluded is that there's really no scientific basis for the discrepancies in terms of sentencing guidelines between the possession of crack cocaine and cocaine hydrochloride. And really the war on drugs was essentially the war on people, especially among the African-American population. So I'm going to be talking about another area of controversy, and that's potentially the role of tobacco harm reduction in tobacco control. And first of all, I want to define tobacco harm reduction. It minimizes harms and decreases total mortality and morbidity without completely eliminating tobacco and nicotine use. And essentially, tobacco control can be considered as a three-legged stool, where one of the legs would be tobacco harm reduction, the other legs would be, of course, prevention and cessation. And tobacco harm reduction does recognize that abstinence or no use is the ideal outcome, but accepts alternatives that reduce harm. Harm reduction has been considered a social justice issue where all smokers, whether or not they want to or are able to quit, are provided as a means to reduce tobacco-related harms. And it's also important to remember that harm reduction is important to consider because of the health disparities that we see in vulnerable populations. And these populations include the high prevalence of smoking among those who are lower SES, that are of certain racial ethnic groups, such as the American Indian population, or who identify as LGBTQ. And for this audience, I think it's really important to remember that there's a high prevalence of smoking among adults with mental illness, as you see in the blue bar, depicted in the blue bar, compared to adults who don't experience mental illness as depicted in the gray bar. And we know these people, the people with smokers with mental illness want to quit, but they struggle with successful quitting. And as a consequence, what we see is a significant reduction in terms of life expectancy at the age of even 40 years old among those smokers that experience serious psychological distress compared to smokers that do not experience serious psychological distress. And harm reduction does make a lot of sense since there are currently 34 million smokers in the US, and there's over 480,000 deaths per year that's associated with smoking. 55% of smokers have made a quit attempt in the past year, but only 7% have been successful. So we really do need a means of reducing the mortality and morbidity among these people that are not successful in quitting. We know that there are some promising experiences with harm reduction, and we see this in the country Sweden. And in Sweden, what we see is with the uptake of snus, which is a smokeless tobacco product sold in Sweden that have lower carcinogens and toxicants in this product compared to some of the products that we sell here in the US. But with the uptake of snus in Sweden, we see an associated decrease of smoking among males in Sweden. And with this decrease in smoking, what you see is also a decrease in lung cancer among males in Sweden. And this is really different in terms of the lung cancer incidence among males in Norway, which has been changing actually because there has been a greater uptake of snus products in Norway as well. So because there's an increased prevalence of snus use in Sweden compared to the cigarette smoking among the males, what has been shown is that there is less tobacco-related mortality and morbidity in Swedish males versus other European Union males. What's interesting in this country too is that there's really no gateway effect that's observed. That is, the risk for progression from snus to smoking is lower than the risks among non-smokers in terms of them taking up smoking. What you also see is that there's a substantial number of smokers who use snus to quit smoking. So it seems like harm reduction would be an appropriate approach to reduce morbidity and mortality. But unfortunately, there's been a history of mistrust of the tobacco manufacturers because of their deceptive practices. And one of the deceptions was the harm reduction experience with the low yield cigarettes. So cigarette manufacturers began to market and advertise these low yield cigarettes, low tar yield cigarettes, shortly after the release of the 1964 Surgeon General's report that linked cigarette smoking to cancer as well as other diseases. And cigarette manufacturers wanted to allay the anxiety that some of the consumers were experiencing as a result of their smoking. So they began to advertise these low yield cigarettes as being less harmful, reducing health risks. And they used descriptors such as light and ultralight cigarettes. And they even encourage cigarette smokers to switch rather than to quit smoking. Now, the way these cigarettes were lower in yield is through ventilation holes that they had put in the filter, the cigarette filter itself. And this allowed the smoke to dissipate from these holes or disperse from these holes. And so what happened is that when machines smoked these cigarettes, you did see a lowering of tar yields as well as a lowering of nicotine. And it's really important to remember that these lower tar and nicotine yield cigarettes actually had the same amount of nicotine contained across the varying yields of cigarettes. So the levels of nicotine were the same. So what happened when people smoked these cigarettes is they puffed harder on the cigarettes or more intensely, and they smoked more cigarettes, and they covered the holes. So they were giving the same amount of nicotine, which led to the cigarettes being more satisfying, which also meant that they were getting the same amount of toxicant exposure, which means that the risk for disease was no lower among those who were smoking the lower yield cigarettes compared to those who were smoking the higher tar yield cigarettes. And unfortunately, the cigarette manufacturers were well aware of this phenomena, but they did not let the public know. So in the final opinion, in the US versus Philip Morris USA racketeering case, Judge Kessler stated that defendants led consumers into believing that low tar and light cigarettes are less harmful than full flavored cigarettes and an acceptable alternative to quitting, even though the defendants have known for decades that light cigarettes offer no clear health benefits. And in fact, in 2010, the FDA prohibited descriptors such as light, low tar, and mild that convey messages of reduced risk of exposure. Now, the cigarette manufacturers continue to develop cigarettes that conveyed less health risks, and they included cigarettes that had reduced carcinogens, but yet premium taste, such as this Omni cigarette. They also marketed cigarettes that could lead to becoming nicotine-free. And they also had products that heated tobacco rather than combusted tobacco. Combustion is what leads to a lot of toxicants associated with cigarette smoking. So heating it would lead to actually less or no combustion products. And they all made these implicit or explicit health claims of reduced risk. Now, the FDA was really concerned at that time. They certainly didn't want to make the same mistakes that occurred with the low yield cigarettes, where cigarette manufacturers were allowed to make all these reduced risk claims with no scientific evidence that would support it. And so the FDA had commissioned the IOM to look at ways to formulate scientific methods and standards by which reduced exposure products could be assessed. And so the IOM committee concluded that for many diseases attributed to tobacco use, reducing risk of disease by reducing exposure to tobacco toxicant is feasible. So what they did is they accepted the concept of harm reduction, which is really a big step forward. They also made a number of recommendations. And one of the recommendations is that you really need to comprehensively study these products to ensure that they are indeed harm reducing on both the individual level as well as a population level. And so they recommended both all basic clinical and epidemiological research that needs to be conducted. They also recommended promotion, advertising, and labeling of these products be regulated to prevent false or misleading claims, and that consumers are fully and accurately informed of the health consequences of using these products. And they also indicate that the products need to be monitored for health and behavioral effects. So in other words, post-marketing surveillance. And so these recommendations actually were the basis of how the FDA would regulate these products. And when this report was actually issued, the FDA they didn't have jurisdiction over tobacco products. It was only in 2009 that FDA was given the jurisdiction of some of the tobacco products, which was expanded. Their authorization over the tobacco products was expanded to other products such as electronic cigarettes and cigars, little cigars, and so on in 2016. So even though this IOM report was released in 2001, there still was a lot of skepticism among the tobacco control community regarding harm reduction. So Mitch Zeller, who now is the director of the Center for Tobacco Products, and I had convened a number of meetings that took a look at the issue of tobacco harm reduction and tried to achieve some kind of consensus in terms of whether harm reduction has a role in tobacco control. And so as a result of these meetings, there was consensus that there is a continuing risk of nicotine-containing products, with combustible products having the greatest risk. We also agreed that nicotine does maintain addiction, but it's really the other constituents that kill consumers. And indeed, the ultimate goal is abstinence from all nicotine products. But for people unable or unwilling to quit, the goal is shifting them to lower risk products, and ultimately nicotine replacement products. So unfortunately, we did have consensus, but over time, the controversy over the feasibility of tobacco control approach grew. And in large reason, the reason why there was more controversy was kind of the explosion of tobacco-derived products that came onto the market. And much of that explosion was driven by electronic cigarettes. And you can see that electronic cigarettes came in various types. And unfortunately too, they came in a multitude of flavors. And some of these flavors seem to be very appealing to youth. And so electronic cigarettes became the bad poster child of tobacco harm reduction. So there grew this chasm between people who supported these electronic nicotine delivery devices, or ENDs, versus those who opposed the electronic nicotine devices. And that also bled into people that supported tobacco harm reduction versus those who opposed harm reduction. So let's talk a little bit about the supporters of e-cigarettes. They the supporters really felt that this was a disruptive, they call it the disruptive technology, that it could be a device because of its appeal, because of the amount of nicotine that's delivered, that can switch cigarette smokers over to a less harmful product. And indeed, a number of studies show that there is less toxicant exposure when people use these products compared to continuing to smoke. In addition, there was more evidence that showed that electronic cigarettes can be efficacious in getting people to quit using cigarettes. Now, those who opposed electronic cigarettes are considered them to be harm elevating, raised the issue that there will be uptake among youth, particularly because of all the different flavors. They were very concerned about the effects of nicotine on the developing brain. They believe that these electronic cigarettes is a gateway to cigarette smoking. And, you know, there is some evidence to support it. There's other evidence that does not necessarily support that. There's dual use, actually was more common than exclusive use of electronic cigarettes, which meant that they were experiencing the same levels of toxic exposure as people that were just smoking cigarettes. So there was no harm reducing effect among the dual users. And there was some evidence that was beginning to evolve that showed that e-cigarettes are in fact harmful to health. They may increase the risk of respiratory harm as well as cardiovascular harm. But again, whether that the harm is comparable to cigarettes is unlikely. But still, there was some concern that these cigarettes, e-cigarettes, can be harmful. Now, along came this epidemic of youth cigarette use, which really made the chasm become a Grand Canyon. There was an observed intake among e-cigarette use among high school students and middle-aged students, and that occurred between 2017 as opposed to 2018. You see a dramatic increase. And the increase continued in 2019 as well. So this really alarmed a lot of public health officials, as well as people in the tobacco control community, some of the people. The good news is in the 2020 survey, you do see a decrease in the use of electronic cigarettes, but still almost 20% of high school students use electronic cigarettes. And what's really disconcerting is among these electronic cigarette users, 39% are using greater than or equal to 20 days in the past 30 days. In addition, what was observed is because of the multitude of the flavors, kids really love the fruit flavors, as you can see, and that's across different types of e-cigarette devices. So you see in the black the preference for fruit flavors, and then of course come the mint flavors, and the candy, dessert, and other sweet flavored e-cigarette fluids. So this led to a lot of concern even among the FDA, where there was a ban on all e-cigarette pod flavors except for tobacco and menthol. And these are cartridges, essentially. And they targeted the cartridges primarily because Juul, which is cartridge-based system, was very popular among the youth population. And so they wanted to target the most popular type of devices. So they took their discretionary authorization away and only allowed the tobacco and menthol flavors in these cartridge-based systems. You heard about the US House of Representatives approving a bill to ban the sale of flavored e-cigarettes. Massachusetts and California imposed a statewide ban on all flavored tobacco products, and that includes cigarettes, which is really good news because menthol cigarettes do lead to greater initiation. People who smoke menthol cigarettes experience a lot more difficulty in terms of cessation of cigarette products. So that's good news. And New Jersey, New York, Rhode Island have banned flavors of e-cigarettes. So you can see that there's kind of a wave of legislation that are banning flavors. But unfortunately, along came EBALI, which is electronic cigarette or vaping associated lung injuries. And there were many deaths that were associated with the use of these vaping, electronic cigarettes or vaping. And so there was really deep concern about these vaping products. Now, it's been shown that a lot of these deaths have been associated, or these injuries have been associated with adulterated THC products. There are some products that were electronic nicotine delivery systems, but the majority were adulterated products with THC. Now, this led the American Medical Association calling for a total ban on all vaping and electronic cigarette products not approved by the FDA for smoking cessation. So in other words, what they were suggesting is that these products should be reviewed by CEDAR and not necessarily the Center for Tobacco Products. So is there a path forward for tobacco harm reduction? I think so. And this is something that I've been working on for several years now, along with my colleague, Eric Donnie. So I think there needs to be a rulemaking that reduces not only the appeal, but the addictiveness of the combusted tobacco products. That is, the FDA can reduce the levels of nicotine in all cigarettes sold in the US to levels that are non-addictive. They just cannot reduce it to zero. That's in the act. So what you do by reducing the levels of nicotine in cigarettes is you push the smokers towards the non-combusted products or towards NRT. And there's a lot of science to show that reducing the levels of nicotine in cigarettes to less than or equal to 0.4 milligrams per gram. So that's 95% reduction of nicotine in cigarettes that are typically found in the marketplace. So a significant reduction in nicotine. But if you do reduce the levels of nicotine to these levels, what you observe is reduced cigarette smoked, reduced dependence and urges for cigarettes. You see an increased quit attempts, and it does not result in compensatory smoking. And the reason why is because the levels of nicotine is reduced in the tobacco filler itself. Unlike the ventilated cigarettes, these have reductions in the tobacco itself. So you need to smoke a ton of cigarettes in order to get satisfying levels of nicotine. And I think Neil Benowitz had written an article saying that you need to smoke about 100 cigarettes a day to get satisfying levels of nicotine. So compensation does not occur. What's been really interesting too, or other people have found that there's reduced cigarettes per day, smoke exposure and or dependence in vulnerable populations. And these populations include those who have serious mental illness, who have anxiety and affective disorders, who have been diagnosed with opioid use disorders, and people that are of lower SES. You also seen reductions among youth or young adults, as well as even non-daily smokers. So reducing levels of nicotine in cigarettes looks really promising. One of the studies that we conducted was to determine whether an immediate reduction, that is a set date where all cigarettes need to be at a certain low level of nicotine, should be instituted, or more of a gradual reduction approach. So gradually reducing the levels of nicotine in cigarettes. And so we conducted a study where we randomized people to immediate reduction, which is depicted in the blue line here, or a gradual reduction as depicted in the red line, or just normal nicotine content cigarettes. And what we found is that if people are assigned the immediate reduction, then you see a significant reduction in terms of cigarettes per day. You also see a reduction in dependence, but you also see a significant reduction in smoke exposure to toxicants as depicted in this particular figure. And you see a greater reduction in those who had been assigned to the gradual reduction group or the normal nicotine content group. What is really concerning is that among those who have been assigned to the gradual reduction group, then you do see some compensatory smoking behavior occur. You see a bump in terms of the levels of smoke exposure, which means that if you're assigned to moderate doses of nicotine content cigarettes, then there may be some compensatory smoking that they can engage on and engage in. And so you don't want that to happen if you're going to roll out a national policy for nicotine reduction. What we also observed is that you have greater smoke-free days among those who have been assigned to the immediate reduction group compared to the other groups. So if you are to implement a product standard for nicotine, it's best to do an immediate reduction group, but there are some concerns. One of the concerns is that, as you can see in this particular figure, there was a greater severity of withdrawal that was experienced in the immediate reduction group during the first week of their assignment to the very low nicotine content cigarettes. So people are going to feel uncomfortable. They're not going to be feeling as uncomfortable as people that are told to just quit, cigarettes abruptly without switching to very low nicotine content cigarettes. But there's going to be some discomfort. We also saw a higher dropout rate in the immediate reduction group, as well as a higher non-compliance to just using only steady cigarettes. That is, they sought out their usual brand cigarettes when they were in the study. So what that tells us is that some smokers will seek out other sources of nicotine, and these sources could be either nicotine replacement therapies or other alternative nicotine delivery systems, such as the non-combustive products, or it could be that they'll seek out the illegal market. So what you want to do is, when you push people away from the combusted products, you want to make the non-combusted products appealing enough that they would be pulled to use them. And, ideally it will be NRT, but, you want to have them shift down the continuum of risk. And so we conducted a study where we assigned people to one of three conditions. One condition was a very low nicotine content cigarette with access to non-combusted products, which included electronic cigarettes, NRT, and smokeless tobacco products, and access to other combusted non-cigarette products. And they include the premium cigars as well as cigarillos and little cigars. And the other condition included normal nicotine. They were assigned to normal nicotine content cigarettes and assigned to the combusted and non-combusted products. And the third group, they were assigned to very low nicotine content cigarettes, but only given access to the non-combusted products. So what we found was that if people were assigned to the very low nicotine content cigarettes, there was a greater uptake of alternative nicotine delivery systems. So it could be combusted or non-combusted non-cigarette products. And if the individual had access to combusted products, then they were more likely to take up these combusted products had they been, if they were assigned to the very low nicotine content cigarettes. So what we observed is that there was reduced toxin exposure only among the people that were assigned to the very low nicotine content cigarettes and the non-combusted products. So what that tells us is that if you are going to have a product standard for cigarettes, you also need to have a product standard for combusted tobacco products. What we also observed is greater uptake of the non-combusted products was significantly associated with greater reductions in combusted product use, greater number of days abstinent from combusted products, and lower levels of this carcinogen, NNK, and it was measured by biomarker total NNL. So what this says to us is that you really need to have products that can pull people towards these safer, toward evidence-based, safer non-combusted products. So that was a small pilot study, and now we're doing a larger study where we're exposing people to an experimental marketplace that is done online. And they have, in this marketplace, they have access to cigarettes as well as nicotine replacement therapies and more, a better generation of electronic cigarettes. They also have access to smokeless tobacco products that are reduced in carcinogens. And we just added a product, nicotine pouch products that just contain nicotine. They don't contain tobacco. It's like a smokeless tobacco product. You put it in your mouth, but it just contains nicotine salts, essentially. So we added that to the marketplace. And what the participants are given are points that they can exchange for these products, or they can keep the points and exchange it for money at the end of the study. So we're just in the midst of the study. We were shut down for several months as a result of the COVID, and now we're picking it up again and doing everything as much as possible remotely. But what I want to do is to share an analysis that we had conducted earlier on in the study to make sure that this experimental marketplace is working. And it just illustrates the type of information that we can observe. And so in this particular study, what we saw is that in one of the groups, what we saw is that there was a decrease in terms of cigarette smoking, is depicted in the red line, associated with an increase in terms of dual use of combusted and non-combusted products. But then later on in the study, you saw that people just began to just smoke cigarettes again, and the dual use of non-combusted in cigarettes did decrease. You didn't really see an increase in the uptake of just exclusive non-combusted products. So that's what we saw in one of the groups. In another group, what we observed was a significant decrease in terms of the cigarette intake. And that was associated with the increase in terms of the dual use of cigarettes plus a non-combusted product, but that decreased over time. And that decrease was associated with the increase in terms of the uptake of just exclusive use of non-combusted products. And so that suppressed the uptake of greater uptake of cigarettes. So I think that these are interesting studies, and again, maybe in a couple of years we'll be able to have the final results. So I want to quickly go over the fact that we really need to also regulate the non-combusted products, which the FDA can do now. So, I think regulation is important. And the criteria by which the FDA regulates these products, the criteria The way that the FDA regulates these products is through the pre-market tobacco application. That is, if a product is not on the market, then they need to go through the FDA to get approval for marketing. Now, the electronic cigarettes are a little bit different. Through discretionary authorization, electronic cigarettes were allowed to be kept on the market, but in September 9th of 2020, all electronic cigarette manufacturers had to put in a PMTA. The FDA can also regulate through product standards. And this is the criteria by which they evaluate the products. One is that they need to determine the risks and benefits to the population as a whole, including tobacco users and non-users. So in essence, they have to show that there is less harm, to the population. They also look at the extent to which current tobacco users would switch to the products if it were available, and the extent to which non-users of tobacco products would begin to use the product if it were available. And so what you want to do is promote the switching, but not promote uptake, especially among the non-users. So I'm kind of thinking about how would you evaluate non-combusted products after devaluing cigarettes, that is, after reducing the addictiveness of cigarettes. So, first of all, you do want to minimize the toxicity of any tobacco product. So you want to make sure that you don't have, for example, with the electronic cigarettes, that you don't have a lot of contaminants in the e-fluids, that the construction of the e-cigarette is sound enough that you're not inhaling metals, or that the voltage of the e-cigarettes can be modified so you can have high voltage, which often leads to higher doses of nicotine, as well as higher levels of nicotine, as well as higher levels of toxicants. You also want to think about the appeal of the product. And if you devalue cigarettes, then maybe we don't need to have all these different kinds of flavors that are available in the market. Maybe we can just confine it to tobacco and menthol flavors, rather than some of the fruit flavors that appeal not only to youth, but also to adults who are switching to electronic cigarettes. That maybe it's not necessary to have fruit flavors, for example, if the cigarettes are not that appealing or addictive. In terms of regulating the addictiveness of these non-combusted products, you might consider a cap on nicotine. I mean, certainly you don't want the nicotine levels to be higher in abuse liability than the cigarette products. But if you reduce the levels of nicotine in the cigarettes, maybe you don't need to have high levels of nicotine in these electronic nicotine delivery systems or other non-combusted products. And then, of course, what you also need to do is you need to regulate the packaging, some of the descriptors, not having descriptors such as luscious strawberries, but just calling it fruit, for example. And you want to make sure that you're marketing towards smokers and not non-smokers. And then it's really important to have communication. And this communication has to what you need to do is you need to make sure that consumers are aware of the relative risk of products. They need to be aware that combusted products are more harmful than some of these evidence-based non-combusted products that are demonstrated to be less toxic. I want to just mention that we need to have more innovations in nicotine replacement therapies. We need to make nicotine replacement therapies more appealing. Having products that are somewhat similar to the electronic cigarette, that there's more rapid nicotine delivery. You give them sensory effects of nicotine. And what we found, or what's been reported in the Cochrane reviews, recent Cochrane reviews, is that electronic cigarettes seem to do better than NRT in terms of efficacy. Unfortunately, there aren't a lot of studies that have been conducted that have done that kind of head-to-head comparison, but you certainly do see a lot more people picking up electronic cigarettes to quit smoking than NRTs. We also need to have a lot more flexibility in terms of how we instruct people to use the NRTs, that they can be done in combinations, which have been more successful than using one nicotine product alone. You can use it as a pre-quit method. They could be used in the long term. Some people need to use nicotine products for a longer period of time than what's recommended on the package. And then maybe even considering nicotine replacement therapy as a harm reduction tool. So in summary, I think there is a path forward. I think we really need to consider reducing the addictiveness of cigarettes. I think also we need to regulate the non-combusted products and innovate in terms of NRT. And with that, I think we can rapidly eliminate the combusted tobacco product use. And this may be really true to occur, or maybe a great benefit among the vulnerable populations. It will reduce the gateway effect because cigarettes are not going to be all that reinforcing, and it will reduce dual use because who's going to be wanting to pay a lot of money for cigarettes that are not very reinforcing at all. It can reduce the uptake among youth, but still appeal to adults when you compare to the cigarettes, which are not very appealing or addictive. And so, you know, I think we could be a little bit more restrictive with the non-combusted products. And of course, you know, with regulating non-combusted products, we will assure that the non-combusted products are in fact reduced risk. And what we can do if we innovate NRT is to provide smokers with NRTs that are more effective. Now, this is much in line with the nicotine strategy that was proposed by Scott Gottlieb in 2017, where he said that they are envisioning a world where cigarettes would no longer create or sustain addiction, and where adults who still need or want nicotine could get it from alternative and less harmful sources. And in fact, in 2018, FDA did issue an advance notice of proposed rulemaking to lower nicotine in cigarettes and potentially other tobacco products. So they're thinking about this proposal. It's kind of on the back burner now just because of all the electronic cigarette issues that have come up, but I think they're still interested in this. And if we do reduce the levels of nicotine in cigarettes, then it's been modeled that 8.5 million tobacco-related deaths would be averted by 2100. So it can make a significant impact in the health of our population. So thank you, and I want to acknowledge we have this incredible team of investigators that have helped to condense some of the research that we're currently conducting. I want to also thank Mitch Zeller, who has been very important in terms of my thinking. This was prior to when he took the directorship of the Center for Tobacco Products. And of course, our funding agency and the tobacco control community. So thank you very much, and I'll end there.
Thank you so much for that talk. That was a really comprehensive presentation, giving us a historical perspective, but also taking us up to date on contemporary challenges, and also giving us a sense of some of the new innovative empirical approaches. So really appreciate your clarity. I guess I'll get us started with one question. You mentioned in the beginning of your talk the elevated rates of cigarette use among individuals with serious mental illnesses. And I was wondering if you could comment on any particular strategies among those individuals to toward harm reduction or risk reduction?
That's a really good question. I think that there are some investigators that are taking a look at how electronic cigarettes might impact the individuals that are diagnosed with serious mental illness. At this point in time, I'm not aware that they've completed, the studies, but, that certainly is one approach, especially among those individuals that where some of the approved FDA medications have not been effective. The electronic cigarettes might be another approach. There is another product that's coming out in the market, or no, it's actually in the marketplace already, and I referred to them, and they were the nicotine pouches that deliver higher rates of nicotine than some of the nicotine replacement products that we have currently on the market. The nicotine pouches are interesting because they don't have the same kind of concerns that the electronic cigarettes have in terms of health risks, in terms of its effect on the respiratory system because of the inhalation. And so it may be that nicotine pouches would be more embraced as a tobacco harm reduction approach than the electronic cigarettes. So that's another area that is, ripe for research is how do these nicotine pouches, how they might affect a population that has truly some difficulty in terms of quitting. So for any younger faculty person, that might be an area to explore. I mean, eventually what you would hope is that the FDA, the CEDAR part of FDA, would try to promote more products or be more accepting of products that are more addictive than the products that are currently on the market, current medicinal products that are on the market. So anyway.
Great. There are some questions in the chat panel, but before turning to those, I don't know if Dr. Levin, did you have any questions you wanted to ask first?
No, I think that, first of all, Dorothy, that was a wonderful talk and helped clarify sort of the morass of information that we get about these alternative products. I was just wondering if you could address, if you know of any research that's been done with studying these non-combustible products in specific psychiatric populations and what their efficacy are in those populations, given that we're often wringing our hands of what to do with patients who continue to smoke cigarettes, and the typical nicotine replacement therapies don't seem to work that well. So although with varenicline, it seems that patients with schizophrenia seem to do pretty well with it, but I'm just curious what your thoughts are.
Yeah, so as I mentioned, I don't think I've seen any results on, and I could be wrong, on people that have serious mental illness. I know that there are some ongoing studies, but in terms of what I would advise is that if the population that has a diagnosis of mental illness, if you find that they have tried products such as varenicline, which tends to be pretty effective, or a combination of nicotine replacement products, nicotine patch plus an ad libitum, and they have been unsuccessful in their attempts to quit smoking, then I have no problem actually in allowing these individuals to switch to a product that has less toxicants, like electronic cigarettes, and to see what kind of impact that might have in terms of their smoking behavior. The issue is we really don't know at this point in time the long-term effects of electronic cigarettes. So, I think the advice would still be to not continue to use that, for the lifetime. That, basically they can use it as a way to quit smoking, but they should consider going off the electronic cigarettes until we get more, evidence showing that it does indeed reduce health risks, so, I think that that would be the way to approach it. However, if there are individuals that can't seem to get off of the electronic cigarettes, then it's better to continue to use them than relapse to cigarette smoking. So, you know, that would kind of be my advice until we get more more evidence that shows the efficacy of these products among the people that are seriously mentally ill.
So here's a question from Margaret Haney, who asks, given your expertise in tobacco regulatory science, what are your thoughts on the cannabis field? Where would you start with regulatory science in the cannabis marketplace?
That's a really good question. I think the Center for Tobacco Products should eventually become the Center for Tobacco Products and Cannabis. And I say that largely because some of the ways that they're evaluating the tobacco products can be certainly used to evaluate cannabis. Of course, you know, they can't become a center unless cannabis is legalized nationally. Yeah, the whole issue of, you know, whether there should be a cap in terms of the dose of THC in these products, you know, really taking a look at what the toxicity of the products are, looking at different delivery systems. I mean, you know, certainly you're going to see more toxicity with the combusted cannabis products versus vaping. You know, those are the pieces of information I think that consumers should know, is the kind of the relative risk of these various products, whether there should be product standards that should be implemented, you know, in some of these cannabis products. And so, yeah, some of the, very much so, that, you know, even regulating how the cannabis products are packaged, what kind of health warnings they should have, and so on and so forth. So a lot of what we're learning from tobacco can be implemented with cannabis, and vice versa too. I mean, the states really have some regulations that maybe we in the tobacco community can learn from.
So our next question, I think you touched upon this issue in your talk, but the question comes from Martin Dockrell, who asks, if our goal is to tilt the balance away from combustibles, would it be better to amplify rather than restrict the appeal of reduced exposure alternatives?
Yeah, that's a really good question. So there's a lot of controversy in the whole topic of reducing levels of nicotine in cigarettes, you know, too. So, you know, I think that people are really concerned about the black market if we do that, and how much, when my colleague said heavy lifting that we need to do in order to actually set a product standard on nicotine levels in cigarettes. So, you know, I think the opposing view is exactly what was stated, which is let's amplify the appeal of the non-combusted products, so people would be more willing to switch. Well, you know, I think that some of the data that were what we've seen in some of the preliminary results that I presented is that even in this climate where we have incredible amount of appeal in these electronic cigarettes, you know, they come in different flavors, and in our experimental market, we do have different flavors, and they come in high doses of nicotine and so on. And even in that climate, what we see is that, you know, people that are actually given the very low nicotine cigarettes have greater impact. There's a greater impact in terms of reducing levels of combusted product use than in the group that has been assigned the normal nicotine content cigarettes. So even when the product's really appealing, there isn't as much shift that we see unless the levels of nicotine in cigarettes is lower. So, you know, if we want to see a significant public health impact, I think that in a short order, then I think we really need to take down the most highly toxic and the most highly addictive product in our marketplace.
And are there other countries that we can turn to or learn from where they've been able to manage the regulatory environment around non-combustibles in a more effective way than we have in the US?
Well, it's interesting in the UK, they tend to be more embracing of tobacco harm reduction. And so, you know, they actually classify electronic cigarettes more as a medicine, and they do have a cap on nicotine levels to 20 milligrams per milliliter, which we don't have here. And I think, you know, certainly they have been successful in terms of promotion of these electronic cigarettes. There is a great uptake. You know, I think that the good thing about electronic cigarettes is that there's greater reach, you know, to populations. And so there's greater uptake of these electronic cigarette devices that will assist in terms of quitting. So I think that they've been, like I said, successful. I think there's been some thought that maybe they do need to increase the levels of nicotine in the cigarettes or in the electronic cigarettes in order to generate more efficacy. So, but I think the UK has been somewhat successful. And as I pointed out in terms of harm reduction, the Swedish experience, now the Norway experience, you know, they're seeing some dramatic decreases in terms of cigarette smoking. The one thing that they do have is that the levels of tobacco use in general tend to be still high. It's just that most of it is snus use rather than cigarettes among the male population. So people have to be comfortable with the notion that there still could be a high prevalence of tobacco use.
Great. Could you talk a bit about how or whether pregnancy might change the equation or thoughts about a harm reduction model?
Yeah, that's, you know, for pregnant women, they should try to avoid any kind of nicotine or tobacco product. You know, I think that they can use nicotine replacement therapy, but it's, I would not advise a woman to be using, you know, whether it be snus or you know, the electronic cigarettes, because there is evidence that you just have more pregnancy complications. Even with the smokeless tobacco products, you see more pregnancy complications. And, you know, the effect of a high delivery of nicotine through electronic cigarettes, I'm not really sure, you know, what the kind of the implications might be on a pregnant woman. So with pregnant women, I'd be very cautious and not, at this point in time, not encourage them to use a harm reduction approach.
So our last question is from Nasser Naqvi, who asks, to what extent is the acceptability of lower nicotine products hampered by reduced condition reinforcing airway effects of nicotine? And what efforts are there to remedy this? For example, by increasing airway sensory impact through non-nicotine constituents, or increase acceptability of low nicotine cigarettes and non-combustion products?
So, so I guess the question is whether there's conditioned, you know, response, the reinforcement from smoking the very low nicotine content cigarettes. And I have to say, yes, there is. You know, we would have expected that people that are smoking these cigarettes would, there'd be people quit because of the fact that there is that condition reinforcement.
Sorry to interrupt, actually, your signal dropped out for a second there, so do you mind just restating that?
So yeah, so I think the reason why we observe that people continue to use very low nicotine content cigarettes, even though they're not reinforcing, via nicotine is because of the conditioned reinforcement. And so, I think that it is of concern. And there was a study that was done by Bickel that said that, pretty much it was an experimental study that indicated that people will continue to use very low nicotine content cigarettes unless there are alternative products that are available. So again, there's that, again, it's the push and pull, phenomenon. You need to have very attractive alternative products that are available. A lot of the studies that we had conducted was primarily ones where we wanted to take a look at, certain kinds of what the threshold of nicotine is, what the approach is. And so they did not have access to alternative products. And so it's right now that we're really trying to figure out what happens to smoking behavior when people are given access to alternative products. So I hope that answered the question.
Yeah, I misspoke when I said that our prior question was the last one. We actually have a couple more. One from Ned Nunez, and maybe Dr. Levin, do you want to ask that question?
Sure, I'll step in, and this is Ned's question. For opiate use disorder, we treat chronically over a long time to prevent relapse. How much is known about, by analogy, long-term treatment with varenicline or bupropion and prevention of relapse over long-term follow-up? Are there data to support that?
So the longer, with varenicline, and there have been studies that show that long-term use of varenicline can reduce relapse rates. And so, I think that that's worth considering. And, as I said in my presentation, I think that the FDA CDER should allow for more flexible dosing or flexible use of nicotine replacement products, and true for varenicline as well, is that, there are individuals that need long-term use of these medicinal products. And so, I think that's a really great idea.
Just keep them on it.
Yeah.
So the next question is that whether the role of nicotine in maintaining cigarette use differs in men versus women, and if that is the case, how might that inform our approaches to harm reduction?
Yeah, that's a really good question, because, certainly there's been a lot of literature showing that females are not as sensitive to the levels of nicotine as males are. And in fact, I think that's one of the studies that we did was to combine nicotine replacement with very low nicotine content cigarettes versus NRT alone. And what we found is that the men seemed to respond more to the NRT, whereas the women responded to very low nicotine content cigarettes as a method to help them quit smoking. And so, that kind of demonstrates but we did do, so the study that we did, the gradual versus the immediate reduction approach, we did take a look at sex as a moderating factor, and we really didn't see any differences. And that was a trial of 1,200 people. And so we had enough power to take a look at moderators, and we didn't really see any differences between the sexes. So that was interesting. I'm not really sure how to explain that, actually.
Okay, great. I think that that is it for questions. Any final thoughts, Dr. Levin?
Not really. I mean, I think what it demonstrates is that even though this has been a long-standing problem, that there's so many new areas that we don't have answers for, and that it's an exciting new area of research for younger people to get involved with, because I think the assumption that we have answers about treating nicotine addiction is really not the case. And Dorothy's work sort of displays that. And we're really appreciative of her speaking today.
Well, thank you so much, Dr. Hatsukami, and thank you for the Substance Use Division and the Hadar family for sponsoring this Grand Rounds. And we will see everyone again in 2 weeks. Take care.
Thank you,
Thank you.
everyone.